Hello and welcome, fellow student doctors. Today, we will discuss the pathways responsible for pupillary control, mainly the parasympathetic and sympathetic pathways. The content of this presentation will set the basis for a clinical exam that you will routinely do. That is, checking to see if the patient's pupils are equal, round, and reactive to light and accommodation. Together, we will build a foundation so you can diagnose pupillary pathologies and excel on the boards and the wards. Let's get started. So, to prepare you for test day, you will be able to 1. Explain the pupillary light reflex. 2. Describe the parasympathetic pathways responsible for pupillary constriction. 3. Describe sympathetic pathways responsible for pupillary dilation. And 4. Explain pathologies that have pupillary involvement. To begin our discussion, let's briefly cover pupillary light reflexes, starting with the direct pupillary light reflex. This slide shows one eye with a brown iris and a black pupil. When light is shown into one eye, the iris contracts and the pupil constricts. This is a normal, direct pupillary light reflex, as constriction of the ipsilateral pupil occurred. That is, the pupil that was directly exposed to the light source. Now, to test the indirect pupillary light reflex, we need to look at the opposite eye's pupil. That is, the eye that is not directly exposed to the light source. So when light is shown directly into one eye, this causes constriction of both pupils. And so, in reference to the eye that was not directly exposed to the light source, this demonstrates a normal, indirect, consensual light reflex, which is constriction of the contralateral pupil. It is called an indirect consensual reflex because the pupil constricted despite not being directly exposed to the light source. Now, let's cover the anatomy of the iris as well as its autonomic control. Shown on the screen is an eye with a brown iris and a black pupil. The iris is composed of two main muscle layers, which are highlighted with a purple circle and yellow arrows. Note the purple and yellow muscles are part of the brown iris. I just made them a different color so we can discuss them more easily. So, the yellow muscle fibers represent the dilator pupillae muscle of the iris. These fibers are radially oriented and under control of the sympathetic nervous system. Since the dilator pupillae fibers are radially oriented, when they become activated by the sympathetic nervous system, they cause mydriasis, or pupillary dilation. Let the D in mydriasis stand for dilation, something that will be animated later. Moving along, the parasympathetic nervous system controls the iris sphincter pupillae, a circular muscle group shown here in purple. Since the sphincter pupillae muscle fibers are circular, upon parasympathetic activation, this muscle causes pupillary constriction, which is known as miosis. Let the lowercase o in miosis represent a pupil constricting. So, to activate the parasympathetic nervous system, light is shown into the eye, causing the sphincter pupillae to contract and cause constriction of the pupil. That is, miosis. However, if that light source is removed, this triggers the sympathetic nervous system and causes activation of the dilator pupillae to increase the size of the pupil, to capture even more light. That is, mydriasis. With that background, let's walk through the parasympathetic pathway that causes miosis. Recall the muscle in the iris that causes parasympathetic-mediated pupillary constriction is called the sphincter pupillae. In this diagram, all structures presented in a purple color operate mainly parasympathetic control, as we will see. So, when light is shown into either eye, the light signal is sensed by the retina and transmitted via cranial nerve 2, the optic nerve, to the midbrain, specifically the pretectal nuclei. Importantly, you must know that each optic nerve sends projections bilaterally to the pretectal nuclei. This occurs because optic nerve fibers projecting from each eye cross in the optic chiasm and then project bilaterally to the pretectal nuclei. With light signals from both eyes, the pretectonuclei send projections to nearby midbrain structures known as the Edinger-Westphal nuclei. The Edinger-Westphal nuclei contain preganglionic parasympathetic neurons, and that is why the nucleus is in purple. I'll explain what preganglionic means in a little bit. Importantly, you must know that the pretectonuclei, like cranial nerve 2, send projections bilaterally to the Edinger-Westphal nuclei, another important crossover in this pathway. From the Edinger-Westphal nuclei, preganglionic parasympathetic fibers hitch a ride on bilateral cranial nerve 3 oculomotor nerves fibers to the ciliary ganglia. Of note, cranial nerve 3 is partially purple because it carries parasympathetic fibers, but cranial nerve 3 is only partially purple as it mainly contains motor fibers to control extraocular muscles. The ciliary ganglion is purple because it houses parasympathetic postganglionic neurons that synapse with the preganglionic parasympathetic fibers from the Edinger-Westphal nuclei. So, from the ciliary ganglia, short ciliary nerves project to the sphincter pupillae muscles of the iris. The short ciliary nerves are postganglionic nerve fibers from the ciliary ganglia that release acetylcholine onto muscarinic receptors found on the sphincter pupillae muscles of the irises. All of this signaling results in miosis, pupillary constriction of both eyes. Overall, there are a couple things I'd like to point out. First, it's important to know that short ciliary nerves specifically shorten or constrict the pupil. This is in comparison to the long ciliary nerves, which actually dilate the pupil, so make sure you know that it's the short ciliary nerves that shorten or constrict the pupil. Secondly, there are multiple crossovers in this pathway, as both cranial nerve 2 and pretectonuclei send projections bilaterally. This is important because these crossovers explain the indirect consensual pupillary reflex, such that light shown directly into one eye causes constriction indirectly in the opposite eye. The boards will test your knowledge of the normal parasympathetic pathways leading to miosis through various pathologies. One that is very high yield is a Marcus gun pupil, which is a relative afferent pupillary defect in the setting of optic neuritis. Due to its high yield nature, we dedicated an entire separate video on that condition. In this lecture, I will discuss other high yield lesions of the parasympathetic light reflex pathway, starting with Argyll-Robertson pupils that occur due to tertiary syphilis. Specifically, the term Argyll-Robertson pupils refers to bilateral, small pupils that do not constrict to light, only to accommodation. Let me explain. Starting with testing the light reflex, when light is shown into either eye, the pupils do not constrict. This may be due to syphilis damaging the pretectonuclei, impairing the normal pupillary light reflex. However, the pupils will constrict if the accommodation reflex is elicited. To elicit the accommodation reflex, you would ask the patient to follow your finger as you move it towards their nose. That is, we ask them to look to the middle and focus on our finger. Now, watch the pupils. This is a normal accommodation reflex. That is, the pupil is constricted as the eyes converged to focus on a near object, your finger. The accommodation reflex is intuitive because the pupils need to constrict to focus the light from a near object onto the retina so we can see it. Overall, the key thing to know is that Argyll-Robertson pupils exhibit light-near dissociation. That is, the pupils do not constrict to light due to the pretectonuclei being damaged by syphilis. However, the pupils do constrict when the accommodation reflex is elicited. This is because the accommodation reflex uses pathways throughout the cortex that do not specifically rely on the parasympathetic pathway presented here. Lastly, to help you remember this condition, on the wards you will see in patients' notes that an eye exam, a pupil exam, was conducted, and you will often see PERRLA listed. This notation denotes a normal pupillary exam, where the pupils are equal, round, and reactive to light and accommodation. Here, the pupils are equal and round, but are not reactive to light, only to accommodation. Another very high-yield application of the parasympathetic light pathway is in cranial nerve 3 disorders, which are based on the rule of the pupil, as we will see. On the screen is cranial nerve 3, the oculomotor nerve, in cross-section. Cranial nerve 3 contains two main types of nerve fibers, parasympathetic fibers on its periphery and motor fibers in the middle. Let the P's in periphery and parasympathetic and M's in middle and motor remind you of the location of these important nerve fibers. Honestly, though, it makes sense that the parasympathetic fibers are on the periphery because they are the preganglionic parasympathetic fibers from the Edinger-Westphal nuclei that hitch a ride on the oculomotor nerve, called motor because that is the main role of cranial nerve 3. And so, if the peripheral parasympathetic fibers of cranial nerve 3 are impaired, this leads to a dilated pupil, because without parasympathetic signaling, sympathetic pathways take over. In reference to the middle motor fibers of cranial nerve 3, if they become impaired, the patient will present with a down and out eye. Remember this finding with the clock trick. Imagine trying to look from 12 to 3 o'clock. You'd have to look down and out to do so. Aha! We are talking about cranial nerve 3, so connect looking at 3 o'clock with the impairment of the middle motor fibers of cranial nerve 3, and you should have no trouble remembering the classic down and out eye of a cranial 3 motor fiber lesion. Now, it's called the rule of the pupil because not all cranial nerve 3 lesions present with pupillary dilation. For example, pictured here is an artery providing blood supply to cranial nerve 3. If that artery develops diabetic atherosclerosis, for example, this will reduce blood supply to cranial nerve 3. However, this will preferentially affect the middle motor fibers, as they are the farthest away from the partially occluded artery. In contrast, the peripheral parasympathetic fibers will be spared. Overall, this results in a cranial nerve 3 ischemic lesion where the middle motor fibers are affected, resulting in a down and out eye, but the peripheral parasympathetic fibers are spared from the ischemia due to their proximity to the artery, so the pupil is not dilated. Conversely, if the patient has a mass lesion, like a posterior communicating artery aneurysm, this can directly push on both the parasympathetic and motor fibers of cranial nerve 3, resulting in an eye being down and out as well as the pupil being dilated. This is a super high-yield association, so let me show you this picture. The yellow arrow denotes cranial nerve 3 and the red arrow denotes the posterior communicating artery, which can develop an aneurysm that pushes directly onto cranial nerve 3 due to their proximity. With that background, let's apply the rule of the pupil in this patient. Do they have a mass or ischemic lesion of cranial nerve 3? This patient has a mass lesion of cranial nerve 3 as the eye is down and out and the affected eye's pupil is dilated. On the boards in the wards, this is commonly due to a posterior communicating artery aneurysm, as we've discussed, or an uncal herniation. Briefly, an uncal herniation occurs when a portion of the temporal lobe, the uncus, as indicated by the blue arrow, herniates and compresses cranial nerve 3, as indicated by the yellow arrow. Now, let's discuss the sympathetic pathway that controls mydriasis or pupillary dilation. Before we review this, know that this chain is occurring bilaterally. We are just looking at one side for simplicity. Overall, this pathway is a 3-neuron chain, and we will go one by one using this diagram. The first neuron originates in the posterior hypothalamus. The posterior hypothalamus serves as an autonomic control center in the brain to regulate the sympathetic and parasympathetic nervous systems. When activated, the posterior hypothalamus sends signals to the second neuron in this pathway, located in the spinal cord, specifically in a section called the ciliospinal center of Budge. The ciliospinal center of Budge is really the lateral horn neurons from C8 to T2 in the gray matter of the spinal cord, as indicated in this cross-section. Now, listen closely. Test makers want you to know that the lateral horn of the spinal cord from T1 to L3 houses sympathetic neurons for the light reflex as well as other sympathetic mediated processes. Specifically, these lateral horn neurons are preganglionic sympathetic neurons that send projections to the superior cervical ganglia. The course of this second neuron is extremely high yield to know, as it exits at T1 and travels along the paravertebral sympathetic chain near the subclavian artery across the apical surface of the lung, making this second neuron vulnerable to injury in neck surgeries or pancreas tumors of the lung, which form at the apex or top of the lung and can directly compress the second neuron. Again, this second neuron is carrying preganglionic sympathetic fibers to the superior cervical ganglia, where they will synapse with sympathetic postganglionic neurons. From the superior cervical ganglia, postganglionic sympathetic fibers will exert the sympathetic effects on the eyelid, pupil, and sweat glands. The path of the third neuron is also high yield, as it travels like a fishnet on top of the carotid artery, through the cavernous sinus onto the eyelid, iris, forehead, and face. Starting with the eyelid, sympathetic activation assists in raising the eyelid via the superior tarsal muscle. Note the levator palpebrae also performs this action, but is not under sympathetic control. Next, sympathetic activation causes mydriasis or pupillary dilation via activation of the dilator pupillae muscle. The dilator pupillae muscle of the iris, the yellow arrows, are radially oriented, and as such, activation causes mydriasis. It makes sense that the sympathetic nervous system raises the eyelid and causes pupillary dilation together, as both actions complement one another in increasing the amount of light entering the eye. Additionally, sympathetic activation also leads to sweat gland activation in the forehead and face. Overall, there are a few key things I want to point out about this pathway. First, signaling occurs via alpha-1 norepinephrine receptor signaling. Also, the long ciliary nerves are responsible for carrying sympathetic fibers to the dilator pupillae muscles of the iris. Use the L's in long and lengthen to remember that the sympathetic fibers of the long ciliary nerves lengthen the pupil. Lastly, and most importantly, disruptions of the sympathetic pathway can result in a Horner syndrome, characterized by ptosis, anhidrosis, and meiosis. Let me explain. Recall this is a 3-neuron pathway that has a relatively long course. So, disruptions along any part of this pathway can result in loss of sympathetic functions. That is, a loss of the ability to fully raise the eyelid, resulting in ptosis or a drooping eyelid, loss of sweat gland sympathetic innervation, resulting in anhidrosis, that is, a lack of sweating on the forehead and face, as well as loss of sympathetic innervation to the pupil, resulting in meiosis or pupillary constriction, as parasympathetic pupillary constriction is now relatively unopposed. Overall, to recall the features of a Horner syndrome, use the mnemonic PAM-Horner for ptosis, anhidrosis, and meiosis. All features of the Horner syndrome. Disruptions along the sympathetic pathway resulting in a Horner syndrome are so high yield that I want to briefly cover my broad differential when faced with a board question that has a patient presenting with ptosis, anhidrosis, and meiosis. Overall, I group causes into 3 main categories that correspond to the 3 main neuron chain of the sympathetic pathway. The first neuron can be injured in CNS lesions. The highest yield CNS lesion to know that causes a Horner syndrome is a lateral brainstem stroke, specifically a lateral medullary syndrome, as pictured here. The features of a lateral medullary syndrome can be recalled with the 4 S's: spinocerebellar, spinothalamic, sensory, and sympathetic impairments. This usually occurs secondary to a pica, a posterior inferior cerebellar artery stroke. Next, the second neuron in this pathway can be injured due to lung tumors, specifically a pancreas tumor that forms at the apex or top of the lung, directly impinging on the course of the second neuron. Specifically, there is a ganglion that is part of the paravertebral sympathetic chain known as the stellate ganglion, located at C6. When a lung Pancoast tumor forms at the top of the lung, it can directly impinge on the stellate ganglion as the second neuron makes its way to the superior cervical ganglion, as shown in this image. Lastly, following the course of the third neuron, it can be damaged due to carotid artery lesions. The highest yield association is a cavernous sinus syndrome. The cavernous sinus is a collection of venous sinuses that has cranial nerves and the internal carotid artery passing through it. Specifically, the carotid artery is wrapped like a fishnet with sympathetic nerve fibers traveling along it. So lesions to the cavernous sinus on one side can result in a Horner syndrome. Please keep this broad differential of CNS, lung, and carotid lesions in mind on test day as causes of a Horner syndrome. As a summary slide, let's discuss anisocoria, which is a difference in the size of the pupils. Looking at these eyes, the two pupils are different sizes. However, you need to conduct a physical exam to determine which is the abnormal pupil. If the dilated pupil is the abnormal pupil, this may be due to a cranial nerve 3 mass lesion that involves the peripheral parasympathetic and middle motor fibers. Not only would the pupil be dilated on the affected side, but the eye would be down and out. Let me ask you, is an ischemic lesion of cranial nerve 3 likely to produce anisocoria? No. Recall that the peripheral parasympathetic fibers are usually spared in ischemic cranial nerve 3 lesions, with only the middle motor fibers being affected. Nice work, student doctors. Now, if the constricted pupil is found to be the abnormal pupil, think of a Horner syndrome, especially if ptosis and anhidrosis are present. Now, let me ask you, what are the three main causes of the Horner syndrome, the broad causes? That's right, CNS, lung, and carotid artery pathologies. Strong work. Time for our flash quiz. The question reads that a patient is undergoing an eye exam. It is noted that the pupils appear small in both eyes, and when light is shown into either eye, the pupils do not constrict. When asked to follow the physician's finger as it approaches their nose, the patient's eyes converge on the finger and the pupils constrict. What best describes the organism that may lead to this presentation? A. Gram-negative spiral-shaped bacterium. B. Gram-negative rod-shaped bacterium. C. Gram-positive spiral-shaped bacterium. D. Gram-positive rod-shaped bacterium. The correct answer is A. A gram-negative spiral-shaped bacterium. This patient's exam findings are consistent with Argyll-Robertson pupils. That is, pupils that do not constrict to light, but do constrict to accommodation. This finding indicates that the patient may have tertiary syphilis, caused by Treponema pallidum, a spirochete, that is, a gram-negative spiral-shaped bacterium. If you missed this, do not be hard on yourself, as it was not a fair question for this lecture, since we did not cover syphilis in depth. However, this is a classic board scenario and exemplifies how test makers integrate across many different organ systems. I want to make you a better doctor and test taker, and questions that catch you off guard like this will do both. So, if you missed it, put it on a note card for me and review it. It might just get you an extra point on test day. Thank you for sticking with me throughout this lecture. Here are a few key takeaways I want to make sure you know for test day. Understand that the iris controls the size of the pupil and is under parasympathetic control, which causes miosis or pupillary constriction via the sphincter pupillae, as well as sympathetic control, which causes mydriasis or pupillary dilation via the dilator pupillae. Know the types of lesions to cranial nerve 3, specifically mass lesions of cranial nerve 3, such as by a posterior communicating artery aneurysm or uncal herniation, cause a down and out eye, as well as for that eye to have pupillary dilation. This is a key distinction to ischemic lesions of cranial nerve 3, such as from atherosclerosis, which usually only cause a down and out eye due to the position of the peripheral parasympathetic fibers and middle motor fibers of cranial nerve 3. Know that pupils that do not constrict to light but do constrict to accommodation are referred to as Argyll-Robertson pupils and represent tertiary syphilis. The Horner syndrome is the highest yield application of the sympathetic pathway and can occur due to disruptions to any of the 3 neurons in the sympathetic pathway. Recall its features with the mnemonic PAM Horner, with P for ptosis, A for anhidrosis, and M for meiosis. Lastly, know the general causes of the Horner syndrome. Mainly CNS lesions, like a lateral medullary stroke, lung lesions, like a Pancoast tumor, and carotid lesions, like a cavernous sinus syndrome. Friends, if you enjoyed the lecture, give it a big old thumbs up and leave a comment, even if it's just to say hello. And always remember, there is a great, big, beautiful tomorrow.